Okay, students, good morning to all of you. So, why do you have why few students today? Earlier we used to have 75, 80 students, but today, like it's so difficult to reach even 50 students. John got 49 boy. These lag line now. So anyway, am I visible and audible to all of you? So, a few of you could write the message. Okay. So because I'm audible and visible, so I'm going to begin now. But it's so sad to see that there are only 50 participants, right? Because what we are going to study today is also a very important topic, right? So we are going to talk about Rhino Sinusitis, its clinical features, diagnosis, and medical treatment. Okay, Rhino Sinusitis also has surgical treatment, but we are not going to talk about that. So rhino and sinusitis. Rhino means nose and sinus means the paranasal sinuses. The inflammation of both nose and paranasal sinuses means rhinosinusitis. So how do you define? Okay, there are different forms of rhinosinusitis. So rhinosinusitis can be defined as inflammation of lining mucosa of nose and paranasal sinuses. Okay, it is as simple as that. Whenever there is itis, it means inflammation. So rhino nose, inflammation of nose, and inflammation of paranasal sinuses. So that is rhinosinusitis. And there are different forms of rhinosinusitis. It can be acute, it can be subacute, it can be chronic, or it can be recurrent. So there are different definitions for all of those classifications. So it is acute when the infection is for less than 4 weeks. It is subacute if the infection is for more than 4 weeks and less than 12 weeks. But if any sinusitis is for more than 12 weeks, so it is chronic rhinosinusitis. And chronic rhinosinusitis is also very, very common. Okay, the patients will have history of several years, right? And again, there is something called recurrent rhinosinusitis. It means if there are more than 3 episodes in 6 months, or more or equal to 4 episodes per year with asymptomatic intervals of more than 10 days. Okay. So what you must know is acute and chronic. Okay, whenever we term is it chronic, it means it is more than 12 weeks, right? And some literature, some they even say that after 12 weeks it is acute. So they have included subacute in acute itself. Now, the types of sinusitis. Okay, so this is what we talked about just now: acute, subacute, chronic, and recurrent. And the sinusitis can be unilateral or bilateral. So, and because you know that there are 4 pairs of paranasal sinuses, so the sinusitis may be limited only to maxillary. So it is maxillary sinusitis, frontal sinusitis, moderate sinusitis, and sphenoidal sinusitis. And if all the sinuses are involved, it is called pansinusitis. Okay, if all the sinuses involved on the left side, left pansinusitis. If all the sinuses on the right side involved, it is right pansinusitis. Similarly, okay, these are and this classification that we are going to talk now, they are not very commonly used. Okay, the single sinusitis or multisinusitis or pansinusitis. Okay, so this is derived from this point itself, right? And again, okay, there are anterior group of sinusitis and posterior group of sinusitis. So this is important because of the drainage. Okay, anterior group, we have made anterior group, and anterior group comprises of maxillary sinus, frontal sinus, and anterior ethmoidal cells. So this is one group because of its particular drainage, and posterior group of sinuses, they have another sort of drainage, right? And okay, this is also important: bacterial, fungal, allergic, and occupational. Etiology. So rhinogenic, it is the commonest cause, followed by, so it means following any form of rhinitis. Similarly, there can also be dental causes, right? Especially in case of maxillary sinusitis, where there will be root abscess, dental procedures, etc. And again, due to trauma, like in road traffic accidents, swimming, diving, right? Foreign body, bladder trauma, and iatrogenic, right? So what we do in the hospital, what the doctor does, like nasal packing and septal surgery, they can also result in sinusitis. And hematogenous causes are usually rare. So what are the predisposing factors? Okay, the predisposing factors are mucosal edema. It can be caused by viral factors, bacterial, allergic, irritant, vasomotor, or barotrauma. Okay, these are very important. Mechanical obstruction, right? Like in DNS or septal spur, polyp, hypertrophic turbinate, concha bullosa, paradoxical middle turbinate, Haller cell, large bolite modalis, agar nasi, onsenate anomaly, nasal tumor, foreign body, and nasal packing. So all of these conditions will cause mechanical obstruction. Okay, let me give you some idea about all these terminologies. We have studied most of them earlier, so this is going to be revision for you, right? So DNS, right? Suppose the patient has DNS on the right side, so it means that there is a proper ventilation, right? No? The physiology is compromised, and because of that there will be stasis, right? And the stasis will lead to inflammation. Similarly, if there is polyp, then because of the polyp there won't be any proper ventilation. Then again, similarly there will be stasis of the secretion and then inflammation. The same thing happens in hypertrophic turbinate. Okay, concha bullosa, it is the pneumatized middle turbinate. And when it is pneumatized, it becomes large and it alters the respiratory pathway. Similarly, paradoxical middle turbinate. So when the shape of the middle turbinate is altered, so it will alter the flow of air and the ventilation. Similarly, this Haller cell is a type of ethmoidal air cell in the relation to the orbit. So a presence will cause obstruction. Similarly, when we have said that large bolite modalis, right? So when it is large, then it may cause obstruction. Okay, agar nasi, it is the innermost ethmoidal air cell. So onsenate anomaly. So whenever there is anomaly of any normal structures, it means that it is going to cause obstruction. And as it obvious with nasal tumor, foreign body, and nasal packing, there is going to be obstruction, poor ventilation, stasis of secretions, and ultimately inflammation. Similarly, there are other predisposing factors like Young syndrome, cystic fibrosis, mucoviscidosis, and dehydration. So these will cause mucus abnormality. Similarly, there are other conditions that will cause mucociliary dysfunction, like Cartesian syndrome, viral, bacterial causes, allergic causes, smoking, pollutants, hypoxia, dry air, extremes of temperature, and synechia. And similarly, miscellaneous conditions like poor health, immunity deficiency, diabetes, and nutritional deficiency, they will get Rhino sinusitis and almost always any other disease. Okay, so this slide is the summary of our last few slides. So let us take some time to understand it. Okay, mucosal edema. Mucosal edema can be caused by viral factors, allergic factors, or many other different factors, right? नाक सुन्नियो हैन, रुगा लाग्यो, नाक बुझेको जस्तो हुन्छ हैन. So it means there is edema of the mucosa, and that is causing obstruction. Similarly, there are other by mechanical obstruction we mean some sort of obstruction because of the foreign body or tumor or any other thing like that. So both of these things will cause sinus ostium obstruction. Because of that, there will be hypoxia, right? And hypoxia will result in vasodilation, ciliary dysfunction, and mucus abnormality, right? So because of vasodilation, there will be transudation of the secretion. Ciliary dysfunction will cause stagnation, right? Ciliary dysfunction, ciliary normally beats backwards, right? So there is the clearance, right? Natural clearance of the secretion, but when the ciliary dysfunction is compromised, it won't get clear. It will just stay there. And similarly, there are some diseases in which there will be mucus abnormality. So the secretion will be more viscous. It will be more thicker than what it normally is. And because of all these factors, transition, stagnation, and viscous secretion, there will be retained thick secretions, and ultimately there will be purulent secretions. Similarly, sinus obstruction will also cause negative pressure within the sinus, and that will result in the negative pressure. So you remember the physiology class, I know about the sinuses are ventilated during the expiration, right? Because of the negative middle air pressure. Right? And during that time, the nasal bacteria will enter the sinus. And when the bacteria enter there, of course, there will be purulent secretions. Right? So this is what a normal sinus looks like on the left side. Right? This is the mucosa. Right? And look here, there is the thickening, edema. Right? The sinus infected and there is edema. Now these are the sinuses, and look here, the maxillary sinus on the right side is normal, and on the left side, look at the turbinate. It is hypertrophied, right? And there are the edema of the lining of the turbinates, right? Here in this diagram, the normal cilia, it beats back and forth, propelling mucus and dry particles out of the sinus. So cilia can become paralyzed during acute sinusitis. Sinus are congested with mucus, and chronic sinusitis may further damage cilia. The mucosal lining becomes thick and scarred. Now bacteriology. Okay, the bacteria causing acute sinusitis and chronic sinusitis. Okay, there are some differences. Right? In acute sinusitis, it is mostly caused by Streptococcus pneumoniae, Haemophilus influenza, Moraxella, Staphylococcus aureus, and Neisseria. In chronic sinusitis, it is Staph aureus, Streptococcus, Haemophilus influenza, Bacteroides, Pseudomonas. Right? There are some similarities, but the order is different. Right? So in the exam, if you're asked this question, make sure that you maintain the order. The commonest are mentioned in the top. Progress. So the severity and resolution of the infection depends on if the sinuses are open or closed, the virulence of the organism, the resistance of the host, and the treatment received. So if the patient hasn't received any treatment, the disease is going to get worse. Okay, similarly, if the host is not very healthy, then the disease is going to get worse. So this single part, this area, is the most important part in nose. Right? If you need to mention. So all of the areas that are very important, right? But this is the most important area, osteometal complex. Because this is the drainage pathway, right? And the interior group of the frontal sinuses and the maxillary sinuses, they all drain through this, and there are so many structures, as many as 8 structures that form osteometal complex, right? So any pathology or any anomaly in one of those structures will cause osteometal complex pathology, right? So these are not all, right? Middle meatus, inferior turbinate, maxillary sinus, these are a few of those components of osteometal complex. The other components are symmetrosis, bullite modalis, agar, right? Osteometal complex is the key area for causation of chronic anterior group sinusitis. Pathological variants of osteometal complex, right? So let us come here again. So I told you this probably is one of the most important sites in the pathology of rhinosinusitis. And any anomaly or any variation in the components of osteometal complex will cause the disease. So let us talk about some of those conditions, not all, right? Concavullosa. This is the middle turbinate, and this is the middle turbinate, inferior turbinate, inferior turbinate. So look, the middle turbinate on the right side is pneumatized, and because of the pneumatization and hypertrophy, so it is causing the obstruction of the osteometal complex. And look at the stasis of the secretion. Right? Normally there should be air. Air is black, right? Black is the answer. But here there is something here, some secretion or soft tissue, and that is why this color. So this is punctular usually osteometrial complex sign. It is around here, inside here. This has become large and it is causing obstruction. And this is paradoxically called middle terminate. The middle terminate is normally like this, I know, but it has come to form this shape. And because of this shape, it is causing obstruction of the osteometrial complex. Right? Look here. This is the CT scan image. Right? Here too, this is the CT scan image, and this is the endoscopic image. CT scan image of the paradoxical middle terminate, and here this is the endoscopic image of the paradoxically curved middle terminate. Right? And these are the large bullite modalis. Bullite modalis is a normal component, but when it is large, it is causing obstruction, and then it will cause the disease. Haller cell. Okay, look here. So Haller cells are the ethmoidal air cells in relation to the orbit. Similarly, there are ONOD cells, which are the air cells in relation to the sphenoid sinus. And because of this, there may be the obstruction and hence rhinosinusitis. Okay, again, I leave it. Okay, nasal septal spore, we have already talked about it. It is called here, right? And because of the spore, there is obstruction, right? Partial obstruction, and there is poor ventilation. And because of the poor ventilation, there will be inflammatory process, right? This is the endoscopic image, right? How septal spots look like. And look here, these are the mucosal disease. I know there is the this the air here, and here is the fluid. I know there is a concavity here, right? And here there is the mucosal disease, and in the ethmoidal air cells also there are secretions, and the osteometrial complex there is obstruction. Now symptoms. Okay, acute rhinosinusitis and chronic rhinosinusitis. They are very common diseases, and many of us have suffered from acute rhinosinusitis for multiple times at multiple stages of our life. Right? And so that is why, because we have suffered from this disease, we very well understand the symptoms. Okay, there can be nasal discharge. The nasal discharge can be mucoid. Mucoid because the normal secretion of the goblet cells, that is mucoid. It can be purulent because of the bacterial superimposition, and it can be blood stained. So one of the common causes of epistaxis is also rhinosinusitis. That is why we order X-ray PNS when we find a case of epistaxis. So nasal obstruction with hyposmia and anosmia. Okay. Obviously, because there will be edema and there will be secretions, so the smell won't be able to reach up to the olfactory epithelium, and there will be hyposmia. And headache and facial pain. Okay. And cheek or eyelid congestion or swelling. Okay, in severe cases only. Similarly, there can be sore throat and cough too. And earache. Obviously, there can be earache because the eustachian tube can get dysfunctioned. There can be, negative middle ear pressure in the middle ear cavity, and due to that, the tympanic membrane will be retracted, which will cause earache. And there can be other constitutional symptoms like fever, malaise, and body ache. So location of the pain. Okay, so the pain is one of the most important symptoms, and there are different types of pain which can help us to differentiate between different sinusitis. In maxillary sinusitis, the pain will be around cheek, upper jaw, forehead, supraorbital. So that increases on bending forward, right? In frontal headache, okay, this is you need to know this office headache, right? Forehead, headache that increases during morning and decreases by late afternoon. So it is called office headache. Right? The patient comes to you, usually the bankers or other people or the teachers. They say that Okay, the headache is very severe in the morning, but later on when I finish my job, it is better. So you need to suspect frontal sinusitis in this case. Okay, and anterior model. The pain is around nasal bridge, periorbital area, which increases with eye movement, and retroorbital pain mostly in posterior model sinusitis. And in case of sphenoidal sinusitis, the pain will vortex, occipital region, and retroorbital region. But for the just I have mentioned it here, but like you do not. This is not very important from the management point of view, because whatever sinusitis it is, the line of management is mostly similar, especially medical management. And because CT scan of PNS is so frequently done in nasal diseases, so CT scan will help us to easily diagnose the sinuses that are involved. But still, it is good to know or good to reach up to the diagnosis just by history alone. Now, what are the signs? Okay, this is what the patient tells you, and signs means what you see, right? So the last slide was symptoms. I know that is what patient told you, and this is what you find out. So when you do the vestibular examination or the endoscopy by the use of Killian's speculum or by the use of venous nasal speculum or thudicum. Okay, you use Killian's speculum in the operation theater, not in the OPT. So what you find are congested and edematous nasal mucosa, and there can be nasal discharge, right, which can be seen on interior and posterior rhinoscopy. So if the discharge is around middle meatus, so it is frontal, maxillary, and anterior modal, because the interior group of parallel sinuses they drain around this area, and if it is superior meatus, so it is mostly from here. And there can be paranasal tenderness, right? And there can be postnasal drip, pharyngitis. So whenever you examine the nose and the paranasal sinus, always make sure that you examine the oropharynx as well. So when you depress the tongue with tongue depressor and you look at the posterior wall of the oropharynx, right? You have the pitch to open the mouth, right? Depress the tongue, and what you see is the posterior pharyngeal wall, right? So in case of sinusitis, not all the secretions that come from the interior ears, a lot of secretions that go behind into the nasopharynx, and from the nasopharynx that trip downwards towards the oropharynx. So you can see a blob of mucus over the posterior pharyngeal wall. So that is called postnasal drip. And there can be granular pharyngitis too. Cheek swelling in case of maxillary sinusitis, and lid edema in modular frontal sinusitis. Maxillary sinus, middle meatus, inferior ordinate septum, superior meatus in modular frontal sinus. So these are the sinus, So to look for ethmoidal sinus tenderness, we press around the medial canthus, right? And for the frontal sinus, we press around the supraorbital rim, around this area. And for the maxillary sinus, we press over the canine fossa. That is how we look for tenderness, right? Okay, we have one of the slide here. Maxillary, palpate over the canine fossa here, right? Anterior model here, middle canthus, frontal. Palpate the floor of the sinus here, and tap over the interior wall, right? So the sinus, the paranasal sinuses, in relation to the orbit, they lie above, below, beside, and behind the orbit. So here looking for the maxillary sinus tenderness, and here looking for the ethmoidal sinusitis. Postural test. Okay, this is a clinical test, but we usually do not perform it these days, right? Because we have better modalities for reflection, so we are going to skip it. Okay, Rhino Sinusitis task force criteria. Okay, now we need to know this, right? the major criteria and the minor criteria. So the major criteria are facial pain or pressure, nasal obstruction, nasal discharge or discolored postnasal drip, hyposmia, anosmia, purulence on examination, and fever. Right? Similarly, headache, fever, halitosis, fatigue, dental pain, cough, earache, pressure. So whenever there are two major factors or one major factor and two minor factors, so you should make sure that it is sinusitis and you need to treat the patient accordingly, right? So these are all the different signs and symptoms, right? You need to know this. Right? There are 13 points, right? And they are not very difficult, right? And you have to imagine what it is also. And major sinusitis so that dental pain is also fatigue on some halitosis on some right? Digestive dysfunction or ear pain right? We have already talked about it. Now investigations are very important. Okay, the history alone will help you to get the diagnosis. Oh no, also. हजुर 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 ए हो ए ए ल ल हुन्छ हुन्छ नि त ल ल हुन्छ 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 जति बेला बोलाइदिनु हुन्छ भोलि त ल ओके okay so diagnostic okay the investigations right the investigations are diagnostic nasal endoscopy okay maxillary sinuscopy x-ray PNS uses of the maxillary sinus CT scan MRI allergic test tooth puncture right endoscopy microswab for culture and sensitivity and fungal culture. So let us learn something about this right. So mostly the history will help us to understand a lot about the disease, right? And it will help us to raise suspicion that the patient is having rhinosinusitis. But still, I know we can confuse rhinosinusitis with many other diseases, especially the fungal rhinosinusitis. So fungal rhinosinusitis is important, and we need to differentiate it well because the fungal rhinosinusitis is erosive. And it is also a medical emergency, ENT emergency, right? So it should be treated right in time. So diagnostic nasal endoscopy is very commonly performed. We do not perform maxillary sinusitis disease. X-ray is a very cheap form of investigation, and it is very frequently done, but it is not very much required because the clinical examination and the history alone will help us to learn so much about the disease and diagnose the disease, right? And whenever we have to do any radiological examination, we prefer CT scan of PNS, right? You see, these are not done diseases because CT scan and MRI, they are very helpful. Similarly, whenever we suspect fungal disease, then we may need to do. Hello. हजुर म फलोवर्स है त म अहिले क्लासमा छु है अनि एलर्जिक टेस्ट है अनि फंगल कल्चर एन्डोस्कोपी माइक्रोस्कोप फर कल्चर एन्ड सेन्सिटिभिटी एन्ड ओके है एउटा यो प्रुफ फंक्चर भन्ने छ है मैले के हुन्थ्यो भन्दाखेरि हैन सेभरल इयर्स अगो हैन when there weren't so many ENT surgeons and functional endoscopic sinus surgery wasn't so developed and available in our setup, right? So what they used to do is, older ENT surgeons, about 15 or 20 years ago, they used to make an incision, not incision, they used to just puncture below the inferior turbinate, X-ray गरायो त्यसमा चाहिँ साइनसमा पुरै पसहरु देखियो भन्दाखेरि हैन टक्क त्यहाँ चाहिँ यसरी छेड्दिने हैन यो साइनस छेड्दिने टुवर्ड्स द डाइरेक्टेड टुवर्ड्स दिस पार्ट द जाइगोमा हैन तर यसको चाहिँ डेन्जर के ट्रोकर एन्ड क्यानुला भन्ने हुन्छ हैन सो द ऑर्बिट इज भेरी नियर एन्ड सो कम्प्लिकेशन्स क्यान रिजल्ट इन ऑर्बिट हैन टक्क त्यहाँ पङ्क्चर गर्यो अनि त्यसलाई चाहिँ इरिगेट गर्यो वाश गर्यो है मैले पनि होइन just I've been practicing including my residency. I've been practicing ENT for nearly 7 years होइन. So in my practice I have seen this true function. I have not done even once होइन, but my professor was a very old human being. He's 75 now, 75. So once he did proof functor just to show us, okay, see how it was is done, right? But this is not preferred these days because the first line of treatment is medical therapy, which is very good, right? The medical therapy we do endoscopic sinus surgery. So this is how diagnostic nasal endoscopy is done, right? Indications for diagnostic nasal endoscopy. Okay, in the patients, right, as I already told you, and to begin the medical therapy, I know just history can be enough, I know. So the patients would not respond to medical therapy. Okay, so and there are anatomic factors preventing adequate examination by the endoscopy. Suppose this is GNS, I know. When you were even if you do endoscopy, you cannot see the inside of the nasal cavity, right? And collection of pus from hiatus seminaris for cultural sensitivity. Okay, objective monitoring, and okay, there are so many things. Perioperative nasal inspection and cleaning. So these are the indications for diagnostic nasal endoscopy. Okay, so you can see that there is some pus here. Okay, by intervals, this is what I mean, right? This is trocar and cannula, right? Like intermeters we puncture, right? And we take out the trocar, and through the cannula we irrigate, and so that all of the pus and everything, right, that is all taken out, and the patient feels so much relieved, right? But these have several complications, and we have better modalities for treatment these days, so that we do not often do this now. And this is the sinoscope or the telescope that we use during diagnostic nasal endoscopy. This is the rigid type, right? And we also have the flexible endoscopy. Maxillary sinoscopy. Enter sinus wall perforated directly in canine fossa between third and fourth. We just skip it. X-ray paranasal sinuses. So this is important from theoretical point of view. In our examinations, in the practical examinations, sometimes you can be asked to read the X-ray. So Waters view or the occipitomental view, it is mostly done to look for the maxillary sinuses. Cadwell's view. So it is occipitofrontal view, and it is done to look for frontal sinusitis. Recess view, lateral oblique, so look for the ethmoidal sinusitis. Skull base view, submental vertical, so to look for the sphenoid sinus, right? If there is airflow level, there is this sinusitis, and if there is mucosal thickening, it means there is chronic sinusitis, right? So because this is very difficult, sometimes it can become difficult, so it is better to go for CT scan, right? So look here, there is some haziness in the maxillary sinuses, the maxillary sinusitis. And here on the left side is normal, on the right side there is haziness. So this is chronic maxillary sinusitis. Right? Look here in the frontal sinuses, right? These are the modular cells and the frontal sinus. So here, now CT scan. CT scan is the preventive investigative modality in case of the disease of nose and paranasal sinuses, right? Because it will help you to diagnose the disease, as well as it will give you a guide to the, it will be a guide to the surgery, right? Look here, opacified right maxillary sinus, orbit here, ethmoidal sinus is here, right? The CT scan is model sinusitis, right? These are ethmoidal cells. Frontal sinusitis, look at the air fluid level, right? This is the air and this is the fluid, right? In the sphenoid sinus, okay? So in the sphenoid, sometimes you can get a thin septus. Okay, sphenoid sinus is a midline structure, right? So there is nothing called left or right, but sometimes there can be a septa and demarking the left and right sides. Okay, coronal axial cuts, plain and without contrast or with contrast if required, they are ordered for. And in the coronal planes, the cuts are of 4 mm or less. The indications in recurrent acute chronic sinusitis not responding to medical therapy before endoscopic surgery, and impending complications of sinusitis. Okay, there are, so we have another chapter for complication for sinusitis. So CT scan helps a lot to understand the complications of sinusitis. Now, MRI can sometimes be done, but we usually do not order it. So only when we suspect a soft tissue density there, we order for MRI. So medical treatment, right? So you need to know this medical treatment. In chronic rhinosinusitis, up to 77% of the patients, they can get improved by medical treatment alone, right? And those who do not respond to medical treatment, right, they should undergo surgical treatment. So we give systemic antibiotics. Nasal decongestant, they can be topical or they can be systemic, right? Antihistamines and analgesics and anti-inflammatory drugs, because there is headache and sometimes there can be a lot of tenderness. Similarly, nasal douching and steam inhalation, and mucolytics like ambroxol hydrochloride. And if there is allergy, then we also do allergic treatment and hot fermentation. So okay, antibiotics. So you already know this, right? Nasal decongestant. The nasal drops like the oxymetazoline, xylometazoline, they act topically, and there are systemic drops like phenylephrine, pseudoephedrine, they are systemic decongestant. Similarly, antihistamines will help CBI. And similarly, the steam inhalation will help to take out the secretions, and similarly, the nasal douching will also help in the similar way. And this is a medicine, ambroxol hydrochloride, and it is a mucolytic. It makes the mucus thin, and when the mucus becomes thin, we expect that it will come out easily. So what is the common antibiotic? What are the common antibiotics that we use? So the combination of amoxicillin and clavulanic acid, so 625 mg BD or TDS, for 7 days, and clarithromycin 500 mg BD for 7 days. Okay, and there are the different antihistamines that you use, and maybe you have taken many of them already. So the systemic ones are cetirizine. It usually comes in form of 10 mg, and it is taken once a day, usually at bedtime. Fexofenadine, the adult dose is 120 mg and taken once a day. Similarly, loratadine, 10 mg once a day. Levocetirizine, 5 mg once a day, and desloratadine, 5 mg once a day. We have only 38 participants by now, or second time at 50 some of fully. So, the second generation, they are not very much sedative, so they can be taken anytime. But still, we suggest the patient to take them HS at bedtime, And similarly, this can become this is an important MCQ question, especially in your PG entrance exam or in the examination for the final examination for PG ENT, sometimes also in your license examination. So there is only one topical antihistamine that we know. So it is azilastine spray, right? This azilastine, it is topical antihistamine, right? And the rest of them, they are all systemic. Similarly, there are nasal decongestant like phenylephrine, pseudoephedrine, right? These are systemic. So there are the tablets that you take like Sinex and Vinex, they are commonly taken whenever you feel that you have sinusitis, So the phenylephrine, ordinary pseudoephedrine used to be used, but now only phenylephrine that plus paracetamol, paracetamol plus phenylephrine, and there is also something called fluorphenyramine maleate, that will help for decongestion of the nasal cavity. Similarly, there are xylometazoline, oxymetazoline, Nazivian भनेर आउँछ, Decon भनेर आउँछ, and there are saline nasal drops, right? So, anti-cold preparations, anti-cold tablets like Sinarest, Sinex, they usually have these three things, chlorpheniramine maleate, right? And pseudoephedrine, right? Or phenylephrine and earlier होइन पहिला चाहिँ pseudoephedrine हुन्थ्यो पछि DDA ले चाहिँ होइन उनीहरूले मानेन अनि all of them now are phenylephrine है this is phenylephrine and this is pseudoephedrine र paracetamol is always there होइन paracetamol is always 500 mg and chlorpheniramine either 2 mg or 4 mg and phenylephrine is 5 mg 10 mg or 7.5 mg होइन tablet amounts so topical decongestant होइन Nazivian है त्यस्तो भनेर आउँछ है so oxymetazoline comes in different forms होइन the adult dose is 0.05% the pediatric dose is 0.025% and there is also 0.01% and then there is saline drop to 2% saline and 0.6% saline right? Now fungal sinusitis right? It is different from acute rhinosinusitis and chronic rhinosinusitis that we know and we should be able to diagnose these conditions in time because this is a surgical emergency you know it is of invasive type right hyphae are present in submucosa it is acute invasive or fulminant if it is for less than 3 weeks right fungal ko barema haina you are not asked a lot of things right but you need to have an idea that if a patient comes to you and he is not getting relieved and so you need to suspect fungal rhinosinusitis and send it immediately to a big center for treatment. And chronic invasive sinusitis if it is for more than 4 weeks. Assuming there are non-invasive allergic fungal rhinosinusitis, fungal ball, or saprophytic. Aspergillus and mucormycosis are the common organisms. Okay, acute invasive fungal sinusitis usually caused by mucormycosis. The predisposing factors are immunocompromised states like AIDS, lymphoma, cytotoxic drugs, chronic use of steroid, and aplastic anemia in diabetes mellitus. And if the patient has used the antibiotics for prolonged time, the clinical features are unilateral nasal discharge with black cross due to ischemic necrosis, right? Cerebral and vascular invasion present, absence of significant inflammation. And complications can frequently occur with fungal sinusitis. Look, the black crusting. The treatment is to remove the precipitating factors, surgical debridement of necrotic debris, antifungal drugs, amphotericin B infusion for 1 to 2 months, itraconazole for 6 to 12 months. In case of chronic invasive fungal sinusitis, significant inflammation and fibrosis and granular formation. So it is locally destructive with minimal bone erosion. Treatment is by debridement and fungal agents. Allergic fungal rhinosinusitis. It can be associated with mortal polyps and asthma, unilateral, thick, yellow nasal discharge with mucin, eosinophils, and circulating crystals. And CT scan, there is radio opaque mass with central area of hypersensitivity due to hyphae. And treatment, it is again surgical debridement, antihistamines, and steroids. Okay, look, this is what fungal sinusitis look like. And the mucin is here, allergic fungal rhinosinusitis. Okay, this is what the allergic fungal rhinosinusitis looks like. Right? So look here in the CT scan. I know also opacity, sorry, there is opacity, but you can see some hyperdensity. I know hyperdensity, right? So when you see hyperdensity, you need to suspect fungal sinusitis. And you also need to look for bone erosion, right? Hyperdensity or regular rhinosinusitis, you do not get to see this hyperdensities. Right? Look here in the axial part, right? Hyperdensity here, right? Now fungal one. Refractory sinusitis with foul smelling cheesy material in nasal sinus. Treatment is surgical removal. No antifungal drugs are required here. Saprophytic fungal rhinosinusitis seen after sinonasal surgery due to proliferation of fungal spores on mucous crust. Right? Surgical removal. So here, what I want to tell you is that do not treat the patient. I know X-ray. When you are for CT scan, okay, X-ray PNS, nasal sinuses, and you can just see the radio opacity. It becomes difficult for you to differentiate between a mass, right, which could be malignancy or a polyp, fluid matter. When there is sinusitis, air fluid level thinking. So sometimes you may be able to find it out, right? And what I know, look at this dreadful condition, I know, fungal rhinosinusitis, I know. Such patients, they are usually treated for a prolonged time in the periphery, and when they come to the center, right, the disease is already progressing. There is a lot of bone erosion, and there is so much of chances for development of complications, right? So that is why, if possible, CT scan can be done earlier, and the patient can be managed accordingly, right? So you always need to differentiate fungal rhinosinusitis from regular forms of chronic rhinosinusitis, right? Okay. So that is all for today, right? So